Thank you for the kind introduction. Stroke is a major epidemic that's completely unrecognized as compared to what's happening with cardiac stroke and what's happening with other diseases, whether it's HIV or accidents. According to WHO World Bank report, in people over 60, it's now the number one disease, according to the World Bank report, in people between 60 and 70, both in males and females. And I think meetings like this are important because they generate a sort of, interest and focus and buzz around it. So what is the basic role of stem cell therapy in stroke? See, there have been a lot of recent advances in acute management of stroke. Neuroprotection, surgical, interventional, we just heard a lovely paper now. But despite everything, there are still a large number of patients who are hemiplegic, patients who are, aphasic, and the role of stem cell therapy is really to assist people with residual deficits. At present, it doesn't have a role in the acute management. But after everything has been done, there will still be patients who have a deficit, and that's where the role is. So the management of stroke, according to me, we should always, prevention is the most, it's the one thing that's completely preventable, and yet exists. So I think all of us need to focus on prevention. There is acute intensive care management, long-term medical management, neuroprotection, surgical intervention in the acute, preventive, neuro-rehab. But now we have this new concept of regenerative medicine. Regenerative medicine is not a drug. We don't use medicines. It's not surgery. It's something different. It's using using healthy cells to replace damaged cells. But whenever we look at any new disease, any new treatment, our first question is it safe? Because our basic principle as neurosurgeons, all of us neurosurgeons function from one principle, the Latin primum non nocere, which means first do no harm. So for an existing problem, maybe it's better to do nothing than to do something that risk causes more harm than good. So what exactly are stem cells? And let's hear what one of the greatest minds... Do you have some volume? Is it possible to get a volume on this?
No, I wasn't aware anyone had it.
Oh, okay.
So, everything you can do. Is the sound on your... Yeah.
I have spent my life exploring the mysteries of the cosmos. But there's another universe that fascinates me. The one hidden inside our bodies. Our own personal galaxies of cells. Today, we are on the brink of a new age in medicine. An age where we will be able to heal our bodies of any illness. All because of cells inside us,
which have special powers. They are called stem cells.
I haven't lived a very normal life. Since my 20s, I haven't had to deal with the distractions that come from being able-bodied. I've led a life of the mind. Stem cells may give you that same freedom, allowing you to pursue your wildest
dreams without ever having to worry about the limitations of your body.
That is one of the most brilliant minds on the planet, Stephen Hawking. And what he said is really very, very true. The stem cell therapy is one field, which is the only field of medicine which has got, in a span of 20 years, 3 Nobel Prizes, which speaks for itself. Our Bible of medicine, Harrison's Internal Medicine, now has a chapter on stem cell therapy, and it actually talks of its role in neurological disorders. So things are changing. So what is the basic principle of stem cells? Stem cells is part of a field of regenerative medicine, and the basic fundamental is use healthy cells to replace or repair damaged cells. That's the fundamental. Take healthy cells that repair damaged cells. The word stem comes from the stem of a tree, and like the stem of a tree can give rise to branches, leaves, fruits, stem cells are cells which can give rise to all other cells of the body. And their properties are they grow indefinitely in culture. So one thing is they grow, two, they can become any cell, and third, they are regulated by intrinsic signals. So once you put them in the body, they seem to know what to do. They home into damaged areas. So here you have cells that have the capacity to multiply, to convert into what you want, and to go and do what the body needs. A brilliant combination of qualities. Now there are different types of stem cells. There's a whole lot of lists. There's embryonic, fetal, umbilical cord, mesenchymal. For want of time, I won't go into the details. So these are all the different types of stem cells that they are. You can get them from the gut, from the bone, epidermal, neural stem cells, from the olfactory mucosa, adipose, Schwann cells. But broadly speaking, for simplicity, I'd like to divide them into four. They are embryonic stem cells, cells that you get from the embryo, from the blastocyst. Normally this is something which will give rise to the whole body, which means at this stage, if you took out the blastocyst, you could convert it into whatever you wanted. Then you can get stem cells from the umbilical cord, there is a lot of work happening in that field. These could be used, if it is stored at birth, it could be used for the same patient, but there are also umbilical cord banks where you can store and these can be obtained. Then there is adult stem cells, which is what we use, and my focus is going to be on adult stem cells. All of us have cells in our body, but from two areas, from the bone and from fat, from adipose tissue. These are easily extractable because we have large numbers. And of course, the newest kid on the block is induced pluripotent stem cells. This is fascinating because this combines the properties of embryonic stem cells and adult stem cells. What we do is we take an adult stem cell. So from the patient, you take a cell. Now you put genes inside it, so you change the genetic makeup and then it reprograms. So these are cells which are autologous. They belong to you, but they behave like embryonic. So the advantage of iPS here, and that's why it got the Nobel Prize 2 years ago. Professor Yamanaka gave the Nobel Prize for his discovery of iPS cells. Now the problem is that all the problems, the controversies, the dangers, the criticism, all actually comes from embryonic stem cells. There are various ethical issues. This is potentially dangerous because in animals it is shown to form teratomas or tumors. So, of course, there are some religious reasons why it is not being permitted in the western part of the world. But all the problems are with this. There are actually no problems with adult stem cells. Unfortunately, the whole thing has got blurred. And I actually compare this is like alcohol and this is like homemade orange juice. And I say, and both are beverages. And you can't say that because alcohol is dangerous, homemade orange juice is dangerous. And that's what's happened. The word stem cells has become, people either are for it and they love it, or they're completely against it. It evokes extreme emotions. The thing is, there are two different types of cells. Autologous is from your own body. We are taking out cells from the patient's body, just separating it, sometimes culturing it, putting it back. It has nothing to do with the dangers, risks, and complications of embryonic stem cells. So I wish to emphasize this, that they are two completely different things. So we've chosen adult stem cells because they are safe, no side effects, doesn't get rejected, you don't have to immunosuppress, you get from the same patients, no ethical issue. We have a regulatory body in India called the Indian Council of Medical Research. It puts that in the permissive category, and there are lots of published reports showing its efficacy. So how do they work? Basically, there are various mechanisms. What they do is, the main effect is something called release of cytokines. These are chemicals. They have an anti-inflammatory effect. There's a paracrine effect. There's a release of positive nerve growth factors. In particular, we've identified BDNF. Then it has got, of course, it activates the resident stem cells that already exist. They self-renew, differentiate, and we have identified angiogenesis, particularly in stroke. This is something that is important because it increases the blood supply to the damaged area. So these are the various mechanisms of actions of stem cells, all of which are useful in stroke. So this is just a list. The transdifferentiation, paracrine effect, angiogenesis, reduces the inflammation, homing, beneficial. And this is a research project one of our postdocs, PhDs was doing. And when we extract the cells from the bone marrow, this is what they look like. These are mononuclear cells. This is what is when we take them out. And at the end of 6 weeks, see what they've converted to. You can see these. You can see the conversion. So this is what we take out, and this is what they become. And what we found very fascinating was that not only have these cells converted, but they are communicating. Look at that. They are actually communicating with each other. These cells are talking. So not only have they converted, but they have communicated. So this was, of course, laboratory work where we created CSF-like environment and we cultured and grew the cells. So this is definitive proof that these facts are converting And not only are they converting, they're live, they're viable, they're converting, but most important, they're communicating with each other. Stem cells can be used in various conditions, from stroke to trauma, spinal cord injury, in ALS, multiple sclerosis, and in children, particularly cerebral palsy, autism, etc. So we've worked with all these conditions with very good results. Now, stem cell therapy is not a cure. People think it's not a cure, it's not a definitive final treatment by itself. It's not a replacement for anything. It's not like asterisks and obliques. It's not a magic, a magic thing that you take it and you become completely normal. All right. What it is, it's part of an overall medical treatment plan and is likely to produce small functional improvements. However, what is small to us may be very important to a patient. Just being able to, get off from a bed onto a wheelchair, be able to do small things which we may find inconsequential, may mean a lot to somebody who has total hemiplegia. This is what it is, and we have to understand that, because sometimes we expect too much from something and then it gets a bad name. Now, why is it controversial? The whole controversy is because in 2001, George Bush banned the federal funding of embryonic stem cell work. Now, he did not ban embryonic stem cell work. He did not stop federal funding of other stem cell lines. What he did was he banned the federal funding of embryonic stem cell lines developed after the time. The rationale was because the Roman Catholic Church believes that life begins at the time of conception. So anything after that is life. And they felt that if you use embryonic stem cells, you are killing them. So there was a religious sentiment. And so he said, you can't create new embryos to make stem cells. In any case, that ban was lifted by President Obama on his first day when he became president. Among the 9 things that he signed, one of them was he lifted that ban. So all the controversies, ethicals, are about embryonic stem cells. About adult stem cells, and that's what I'm going to talk, has no major controversy, no ethical issues. In fact, adult stem cells have been used for hematopoietic conditions for 30 to 40 years. They've been used regularly. We're just using them for a newer indication. And like I said, putting them in the same category is like putting alcohol and homemade orange juice in the same category. The present situation is in many Asian, South American countries, it's a permissive form of treatment. It's not experimental anymore because there are enough publications, but yes, it is unproven. By standards of evidence-based medicine, because we don't have class 1 evidence, we don't have prospective, randomized, placebo-controlled trials to show, so it's not a standard of care, but it tells us, it gives us direction, it tells us of something that's possible that is not possible by any other way. So yes, it is unproven. So what's the basis of using it? There is the World Medical Association Declaration of Helsinki, which is the ethical principles for medical research involving human subjects. And number 37 says, in an individual patient where proven interventions do not exist or have been ineffective, a physician may, use an unproven therapy if, according to the physician, there is hope of saving life, re-establishing health, or alleviating suffering. But it adds, of course, that if you do this, it should be the object of research and designed to evaluate in safety, and all this information must be recorded and, where appropriate, made public. So there is an ethical basis to using stem cells in cases where there is nothing else, because once somebody has hemiplegia, it's 1 year, 2 years down the line, you have hemiplegia, you have aphasia, you're not improving, and there is nothing else available, you would fit into this category as per the Helsinki Declaration. Now, how do we do it? It's a simple, very simple 3-step process. We do a bone marrow aspiration in the operation theatre. So this is the bone marrow, and you can see taking bone marrow is coming out. This is the anterior superior iliac spine and the lower part of the front over here, and that's the bone marrow that's coming out. We normally collect about 100 ml or so of bone marrow, and then that's the process, that's the technical protocol, how we actually separate the stem cells and do the count. And we normally take about body weight into 10⁶ cells. And then the stem cells are separated in the laboratory. This is the process, how by using the technique is called the density gradient. And this is a well-described technique. It's there in literature. It's a standardized technique called the density gradient technique. And once this is done, it's a relatively simple procedure. What you get is that the coat over here, this is called the Buffy coat. And this is the collection of mononuclear cells and 334 cells which collect. And then we collect them all together and put them, and finally this is what we get. The cells are all counted, the viability is checked, detailed evaluation is done to know what we are exactly putting in, and then finally through a lumbar puncture, the cells are injected. So it's a very simple process. We are taking out bone marrow, separating the cells, we're not even culturing them, and then putting it back intrathecally. So what are the clinical results? What I'm going to present to you is from a paper that we've published in Stroke Research and Treatment. This is our paper, which actually talks of the use of autologous bone marrow-derived cerebral in chronic stroke. This is, we had studied 24 patients, that's our paper, and there were 24 patients studied. You can see the mean age is 57, male, female, 15 ischemic stroke, 9 hemorrhagic, about mean time since stroke was about 40, and overall 76% of the patients showed functional improvements. I'll discuss the results. We use something called FIM, which is a test of checking the functional improvements, and you can see the mean before and after, and there is a significant difference between the before and after, statistically significant. The clinical differences are small, but they matter to the patient. In any case, they are statistically significant, and if we see the improvements out of our 24 patients, 12 showed, that means about half the patients showed improvement in ambulation. 10 of these patients showed improvement in hand function, 6 their standing balance improved, 9 their walking balance, and their FIM improved in 9 of the patients. Now, we studied our data more to see, we separated the results into patients who had come to us within 2 years of the stroke and more than 2 years after the stroke. And as you can see, it's obvious that those who, if you see the red is 2 years. So the patients who came to us within 2 years actually have done overall better as compared to the ones who have come to us more than 2 years, which is logical. Then if we see, we divided that into age. So below 60 and more than 60, again, we saw that there's a dramatic difference. Those who came to us below 60, the improvements are, the red is below 60, as compared to in all these symptoms, the improvement is, there is a significant difference in everything. In other words, the younger the patient, the more likely, the more improvements, which may mean that maybe for older patients, instead of using autologous, we may want to use some other form of cells, because as you grow older, the cells, their ability, their potency, everything decreases. So maybe it has to do with the type of cells, but there's a definite difference. So those who come to us within 2 years do better, those who come to us less than 60 years do better. Then we of course studied the difference between ischemic and hemorrhagic, and again we found that ischemic patients, there was a greater percentage of patients had shown an improvement as compared to hemorrhagic. So the potential of recovery is more in ischemia. And we studied the left and right side of the brain, more or less not, like a right stroke versus a left stroke. Slightly we have seen that those who have a right stroke have done better, those who have done a left stroke have done less better. Now these are functional changes. This is a PET CT scan image, and you can see this is before. Now you can see this damage before, and in this you can see that this damage has cleared. This blue is hypometabolic areas. Now you have to note that the major infarct is still there. It's not that the dead brain has become live, but obviously there are areas around it, the penumbra, that seem to have improved. So, now if you look here again, you can see this is Liberia, and you can see that in the post, this has improved. This is another patient. This is a second patient. Here's a third patient. Now you can see this whole area before, and you can see that in the second, this is gone. These are PET images in which the blue is hypometabolic, green is normal. The whole brain should actually be green. Yellow is a little less than normal, and blue is hypo. So the improvements aren't dramatic. Okay, it's not that the infarct is gone, but the fact is there is a definite improvement. You look at this and you look at this. Now, of course, one may question, would this have happened by itself? That's a possibility because you don't have controls, maybe, but it's unlikely because these patients have been, many of them have had stroke for at least more than a year. So it's unlikely that this is, but we've noticed this in most of our patients, that there is some improvement. Increased FDG uptake is seen in all the patients. Were there any adverse events? There was no mortality, none of the patients died, there was no neurological deterioration. There are some problems, like 10% of the patients have spinal headaches, people have low back pain, pain at the site of aspiration. But apart from these minor, there were no major adverse events. The limitation was, first, this is non-randomized and there's no control. It's a single center, it's a very small sample, and the group is a little heterogeneous. We need to study ischemic separately from hemorrhagic because they're two completely different groups. So here are just some case reports that so as you can see him before, and he was completely even with support, difficult to get up. And later he's able to get up himself. This is 6 months after the therapy. They're small changes, but to the patient, they are important. This is something most common. Their fingers which are clenched, invariably all of them, for some reason the hand improves a lot. They actually open up. So these are things that he could not do earlier. Like I said, the hand for some reason improves, and this makes a big difference. I mean, they can use their mobile, they can eat, they can do small little things. Now see the difference before and after. That's the last video, just got 3 patients only. All these videos are 6 months after the therapy. Look at his leg, how he's swinging the leg and walking. Now he's actually taking steps. It's not a swing. It's actually, he's able to lift his leg. So these are some of our other papers. That paper was a study of 200. These are separate case reports. It's published in Case Reports on Medicine. This is, in the Indian Journal of Clinical Practice. So these are some of our other papers in Journal of Stem Cell Research and Therapy. Apart from this, we have treated patients of autism, CP, motor neuron disease, muscular dystrophy. So stroke is actually our smallest number. We've treated many more. Children do much better overall. So. And these are the results as compared in children and other things. And these are some objective reports on autism. Now here you see autism, you can see this hypometabolic area before. And you can see much of it is cleared later. And this is a child of CP, this is before. And you can see much of it is cleared later. In a case of head injury, you can see before and you can see after. So it's obvious that there are lots of positive changes that are happening. So what's the future? The future, I think, is going to be a combination of stem cell therapy with others. For example, we are now looking at hyperbaric oxygen. We've seen some very good results with hyperbaric oxygen. We're planning to combine the use of hyperbaric oxygen, where oxygen is given under 3 atmospheric pressure. Normally, it's only a hemoglobin takes blood, but when you give it under higher pressure, it goes through the plasma. And preliminary research is showing that actually stem cell therapy with hyperbaric gives you better enhanced results. We've done some pilot projects. We do this surgery called carotid endarterectomy. I'm a neurosurgeon. I do a lot of this vascular work, and this is the incision we make. We open the blood vessel, and this is the plaque. You can see this shape like the vessel. This is like a cheesy thing which blocks the blood vessel and causes a stroke. So once we remove it, the blood supply improves. And we've done some initial pilot project where we've injected the stem cells. After restoring the circulation, we've injected these stem cells directly into the blood vessels. These are very small cases. We've just got some ethical approval for a very fascinating project, which we still have to start. We are now going to move to acute stroke, because there was this whole discussion that when we are now, all the patients you saw before were patients a year after therapy. So if it works later, why not do it acute? Why? So what we are doing is we are taking acute stroke, and within a 7-day period, they will be randomized into 4 groups. There will be a prospective randomized study, standard medical treatment. Then there is something called a superficial temporal artery to middle cerebral artery bypass. Of course, this project is only for middle cerebral artery infarcts. This is something which was done earlier but given up, and we are re-looking at it. Then just give stem cell therapy and do the bypass and give stem cells along with that. To get ethical clearance, we had to do a few cases to show to our ethics committee of its safety, and the results are very, very amazing. We had patients who were completely paralyzed, who've completely come out. But but unless we compare to this control, we won't be able to say for certain. So this is a 2-year project, but it's fascinating, because if we can show that in the acute setting, you revascularize, and I'll show you what an STMCA bypass is. See, there is a vessel below the scalp, this is the vessel below the scalp. It's called the superficial temporal artery. So it's very easy, because you just make a skin incision. It's lying just below, and what we do is we open the skull, and after opening the skull, we identify the middle cerebral artery. The majority of strokes, the large number of strokes, are because of middle cerebral artery occlusion. So the block is before that. What we do is we now take this vessel which we have got from below the skull and suture it over here. When we suture it over here, this now restores the blood supply, much like a coronary. So this is the blood vessel, you can see, and finally here the blood vessel is sutured to it. So now the brain is getting blood supply from the outside, from the external circulation, and we believe that if we combine this with stem cells, we'll get good results. So my conclusions are that stem cell therapy is a potential form of therapy for patients who have residual neurological deficit. When everything has been done, there are small improvements. You saw the improvements. They aren't dramatic. It's not that somebody who's paralyzed and now started jogging or running the marathon or using his hands, but they are important. What we do, this is autologous bone marrow derived stem cells, are safe and there's no major adverse events. It's not a replacement for any of the existing treatments, but it's an addition to existing and whatever else is happening. And of course, larger controlled studies need to be done. I'd like to end with this speech of...
Today, with the executive order I am about to sign, we will bring the change that so many scientists and researchers, doctors and innovators, patients and loved ones have hoped for and fought for these past 8 years. We will lift the ban on federal funding for promising embryonic stem cell research.
What he says next is very important. I want you to hear that.
There's no finish line in the work of science. The race is always with us. The urgent work of giving substance to hope and answering those many bedside prayers, of seeking a day when words like terminal and incurable are potentially retired from our vocabulary.
Thank you, Regent.
Thank you. Thank you for this fascinating talk. Is there any questions?
Thank you for very, very interesting talk. Would you say that the transplanted stem cells are more involved in integrating with target tissues, or alternatively, do you think the stem cells are responsible for secreting beneficial factors, and that maybe the stem cells are short-lived, but the effect is beneficial because of some of the secreted factors, or a bit of each?
Actually, it's a bit of each, but the latter, the secretion of beneficial factors, is the most important thing, because we have, they are definitely growth factors, and in particular, we've identified BDNF as a growth factor. So see, it's not, and what it does is when you have these positive chemical growth factors released, it's not only working on the damaged tissue, it's working on the rest of the brain too. So you have the rest of the brain that's also sort of charged. Now, if you saw the PET images, the main infarct remains, but the area on the periphery, the stuff that's not dead but not functioning, the penumbra, so to say, that seems to have cleared up. And that accounts for these small improvements. So I think, I personally think that the initial improvements you see, because you sometimes put them in and within a week's time they're moving. Now that, the cells can't integrate in such a short time. And then we have improvements that we see which are later, you know. So I think it's a three-phase thing. You first have positive chemicals released. The second part is there's definite angiogenesis. And the third is that these, you know, some of them will integrate with the target tissues. Because they are, research projects, you know, you can, there are some papers from the United States where they've tagged nanoparticle dyes to these cells. And when you put them in, and you can see them on MRI, you can see where they go. And they found that 50% of, and there was a control study where the nanoparticles were sent without stem cells, you know, the two things. And they found that 50% of all the nanoparticles where the stem cells were injected were all around the area of damage. This was done for spinal cord injury. Whereas where it was, when the nanoparticle dyes were given without the stem cells, they were all over, they were just nowhere. So obviously these are homing into the damaged area.
Thank you. What can you say about negative results of stem cells therapy? Really, you look at first of all, and second, what can you say about the decrease of positive effect on the second year after treatment in patients with hemorrhagic stroke, especially like I see?
Okay. So first part about the harmful effects. In adults, we have found stem cell therapy when done with autologous adult has no harmful effects in adults. However, in children, there is. So we've done a lot of work with autism and CP, and there is a 6% increase in epilepsy. And we've published that. So there's a paper in Neurological Disorders, we've published our adverse events. So, but that's then children. And it's then children who already have an incidence of epilepsy and whose EEG is abnormal. So if the EEG is normal, they don't have it. In other words, if there is a predisposition to epilepsy, there could be an increase. It's manageable, but it's an adverse event. With this stem cell therapy, there's no possibility of any side effects because it's all autologous cells. We are taking them and putting them there. We've got sort of 7-year data of patients, and we are following up everyone. And nobody has so far developed tumors or anything funny like that. So, well, I can tell you for certain that at least for 7 years, nothing goes wrong. Now, if something happens after 15 years, we wouldn't know. But it's unlikely if something has not happened in the first 7 years. The second thing is you asked about, now, like I showed you in my data, hemorrhagic strokes respond lesser than in ischemic strokes. Because the damage in hemorrhagic stroke, it's not just the tissue that's damaged, because the tissue is destroyed. In hemorrhage, when there's a hemorrhage, the brain there's gone. Whereas in ischemia, the brain is still there, okay, but it's not functioning. And also, in ischemia, there's no raised intracranial pressure at the time of, whereas in this, there's raised intracranial pressure. What we have found is that the improvements, once they come, they remain. But yes, you're right, after a period of 1 or 2 years, the improvements plateau off. They don't, but the improvements which have happened don't go back, they don't reverse. But the improvements stop at a particular point. So that's where that's where we are looking at other modalities like hyperbaric, like the use of neuroprotective drugs. We're trying to see what can we do to enhance this or sustain this. And this is work in progress. This is going to take time. Also, this needs to be combined with a very extensive neurorehabilitation program. So all this goes hand in hand.
Thank you. Can we put our hands together for the
Oh, thank you.
Thank you.